Amidst the COVID-19 pandemic, Whitespace Health sponsored a session at MGMA's Medical Practice Excellence virtual conference. Here is Cindy Nyberg of Fulcrum Strategies, sharing the tools she used for financial success and recovery during unprecedented times.
Good morning. My name is Cindy Nyberg. I'm the CFO and Strategic Planning Consultant for Fulcrum Strategies in Raleigh, North Carolina. Basically, when people ask me what I do is I help doctors. More importantly, I help their administrators. As I was formerly a CFO and did several operations projects for a large neurology practice, and so I've walked in your shoes. I understand what your days are like, and I hope some of the strategies that I found successful, you'll be able to take back to your practice. And I would also like to thank MGMA for hosting this annual conference. I've attended them since I joined the healthcare industry and always found that it was beneficial and I learned something. And I'm so happy that the show is still going on in our virtual experience. I'd also like to thank Whitespace Health for sponsoring this. And more importantly, I would like to thank you for attending and sharing your valuable time with us this morning. These are our learning objectives. The first two, talking about pre-COVID, COVID, and post-COVID financial realities, and then identifying some of the upcoming challenges. We're going to go through quite rapidly in the interest of time, and then I'm going to share with you some of my strategies that I've utilized in my prior positions with current clients and also during COVID. And so let's get started. What was our pre-COVID life like? It seems like it was a million years ago. It was great. 2020 was off to a good start. Unemployment, 3.5%, setting records every month. Wage growth, 3.9 to 4%. Labor participation rate, 63.4%. And many practices were enjoying revenues and patient visits up to as much as 16%. Again, in February, 2020 was off to a fantastic start for us. Then, where were you when the realities of COVID turned from a news story and someone else's reality to your own reality? We all know about those key dates in your lifetime that you will never forget. Where were you on 9/11? For me, the COVID date was March 12th of 2020 in North Carolina. I was at my niece's soccer game. All of a sudden, parents started coming in Raleigh, North Carolina. Basketball is really big here. And they were talking about the NCAA basketball tournament was canceled and that the ACC tournament was only going to do play without fans. And eventually it was canceled. Earlier that day, I had been in a meeting with a large hospital and health system, and instead of talking about a relationship, we were talking about how to prepare for COVID. That became real to me. And that night, my husband was complaining about all this shutting down. He's an engineer, and it wasn't real to him. And I said, sweetheart, our hospitals are preparing. We have to help them. And that was when it became real to me. And where were you? So COVID immediately became a perfect financial storm. Essential services only in a lot of states. Our doctors and administrators experienced something we've never ever experienced before: empty schedules. I talked to one of my clients early on. Their production was immediately down 85%. That made everyone scramble. And that also made COVID become very real. On March 17th, President Trump signed the executive order saying that Medicare was going to pay for telehealth visits. I watched practices really come to the forefront and implement those within a week. Cash flow modeling, that was me. That was my biggest tool and my biggest contribution that I could make to practices that I helped. I put together cash flow models that started and projected out to June 30th I could show them where their shortfalls were, where they needed borrowings, whether they could pay their, may have partner draws. And so that was a very important tool for me. It's something I highly recommend for everyone to do. Furloughing staff. A lot of practices, when they saw the empty schedules, they furloughed staff as a reaction. I tried to develop a payroll model and get people to really think through how they were going to do this and to utilize their staff for the benefit of the practice. Utilize their billing to clean up old AR. Get their providers to clean up old charts that weren't, that hadn't been signed yet and bills hadn't gone out. Do projects, do training, but then also have the flexibility to be able to help their staff meet their families' needs. I thought this was an opportunity to help to build a team and try to do more loyalty. And then in the first weeks of April, we went through the trials and tribulations of getting PPP loans. I think we all experienced changing rules. We didn't know what was included, but we have to give the government a lot of credit because they did it the fastest I've ever seen, and it really gave us a lot of breathing room. And most of all, we were worried about keeping our patients and our staff and our providers safe. We didn't go into meeting rooms together anymore because, like, I still have a practice. We're still not meeting in the same room because we didn't want our providers to all get sick at once. In the beginning, when one staff member or provider got sick at an office, the whole office closed down. We had to secure PPE, and that was an additional expense. So there was that stress on practice administrators and providers and owners and people that were helping them. And what I am saying is, through this perfect financial storm, I'm very proud to be a part of this industry. Even though I wasn't in the trenches, I watched people step up. I watched people take care of their patients, and they kept their staff safe. And I think there's something we all need to be proud of because we have never experienced this before. So the post-COVID world, the biggest question here is, are we there yet? I don't think so, especially as we're seeing spikes across the country. My niece, who I was at her soccer game, was really upset about her soccer season being suspended. And at first I said, oh, sweetheart, you just divide everything down, big problems into little problems, and all we need to do is get to April 15th. I don't, in my wildest dreams, and when I talk to other people, I never expected to be talking about this still in October. So is your practice back to February 2020 levels yet? I thought maybe once the states lifted their mandates that the patients would be coming back in. But I can tell you, as a patient myself, I've taken my time to go back and catch up on my visits. One practice I do work for, and I do a financial model for them every month. I kept saying, you know, your revenues are still up over 2019, but your visits are down. And one of the partners had a great question because I've been doing the financial modeling for a while. They're used to it, and they ask questions and they're engaged. He said, well, how can our revenues still be up, but our visits are down? So the first thing I could do is do a visual for them. I'm doing this graph that shows them that one of the reasons why the revenues are still up is because we did clean up some old AR, and I did have a provider catch up on their charts. But also revenues lag. Visits, we know that when we're in the revenue cycle, we have our days in AR. So I thought this was a very good question by a partner, and this helped for them to see the visual on what is happening with their revenues and their visits. The one thing that's being very apparent and a little bit surprising is that the recovery is flat for this group. And, and I've got another group that I do a model for. It's all over the place. So what we expected was a big return. I think it's just a little bit slower. And because we're still dealing with the complications and the safety issues of the virus. So now moving on to my second learning objective, and that is to identify and develop the strategies that I think are going to meet the upcoming financial challenges. So first, we're going to identify the top 5 challenges post-COVID and beyond. Again, what I've said in the beginning is some of this we've talked about for years, and I think the catalyst, COVID, can really be the catalyst that's going to kick us into gear. First, payer mix changes due to unemployment. The catalyst for changes in the payer reimbursement strategies. Consumerism. The utilizations and the implications of telehealth. And surprise billing legislation. Let's start with the payer mix challenges. As people are unemployed, and the longer this lasts, the more the risk is, you're going to have more patients moving on to Medicaid and exchange plans. All right, we all know Medicaid reimbursements are much lower than your managed care reimbursements. And depending upon what market you're in, sometimes the exchange plans can be lower. You're going to have movement out of employer-sponsored plans because the patients are no longer employed. You're going to have higher private pay or self-pay patients. And another challenge of this is for a lot of patients moving into the exchange plans, those exchange plans have higher deductibles and coinsurance. So my question for this is, do you have an approved patient financial responsibility plan? Do you also have the technology available to make it easy for patients to pay their bills? Also, are you modeling a change in revenue? You know, are you modeling, do you have a forecasting system that says, okay, I believe 25% of my patients are going to move from 150% of Medicare to Medicare? Or do you have that ability? Because I think right now that's going to be very, very important. Payer reimbursement strategies. We've all talked about these for years. Capitation, bundled payments, value-based payments, specialist clinically integrated networks. A lot of markets are moving to these more rapidly than others. I think this, again, is going to be the push for most markets to be looking to these reimbursement strategies from fee-for-service. Some examples, you know, I've got payers in markets that when we try to get a fee-for-service increase, they say, no, we're only giving shared savings or value-based agreement reimbursements. We are giving no more fee-for-service. I have a market where ACOs and shared savings has been primarily in for primary care physicians. Well, now I've got ACOs reaching out to my specialists because what are the ACOs telling the primary cares is that some of your cost drivers are your specialists and you need to control those. Well, that's really difficult for providers to control other providers with how they order. So they're starting to try to get the specialists participating with them as well. Also, we're hearing about specialists forming their own clinically integrated networks. And once again, capitation, it's been a while. That was prior to when I joined the healthcare industry, but we've got a really interesting example in North Carolina. Blue Cross Blue Shield in North Carolina in July of 2020 has offered a new program, Accelerate to Value. It's available for primary care physicians, including OBGYNs. To participate in this, and what this program does is it provides those practices with assurance that they will keep their payments at 2019 levels, their Blue Cross payments, from July 20 to December 20 and through the whole year of 2021. To participate, the practice has to agree to remain independent. If they sell, they have to pay back that money. They have to agree to join an ACO by 12/31 of 20 that was designated, and they have to agree to consider a capitation agreement effective 1/1 of 22. Blue Cross has been rapidly implementing this. It was amazing how fast it came out of the blocks. It was also amazing how fast my practices got some payments. And all they have to do is consider the capitation model, but this gets them talking about it. And I think you're going to see more and more of this as we go on. Consumerism. We've talked about this for years. We've talked about price transparency. How many times have we been in a meeting room when we've said, my goodness, our patients can go to the grocery store and know what a cost of a gallon of milk is, but they can't know what their MRI is going to cost them until their insurance processes and they get that EOB. I think you're going to start to see price transparency. Again, we've had an executive order that increased price transparency January 1 of 21 for hospital services. I believe if this is successful, practices need to be able to prepare to extend this into their ambulatory services. When I was in the practice, that was just the beginning of the provider quality ratings. And at first, we got this stack of envelopes, one for every provider, showing what their tier was or what their cost quality measure was. And, what level are they? And at first you didn't know what to do with them. And what I learned real quickly is that you needed to pay attention to them. You needed to make sure they were correct. One example was I had a specialized pediatric provider that was billing a lot of level 4s, but she got a poor cost rating because of those levels. Once I explained it to the managed care company of what she was doing, they changed her cost rating because they understood why she was doing a lot of level 4s. I look at these provider quality ratings and the patient satisfaction surveys like a diagnosis code on a patient. When I was in charge of the billing department, I said we need to be really careful on what diagnoses we put on patients and make sure they're correct, because it's hard to change them. And now you've got people data mining, companies developing these data mines. So then are we going to start seeing Priceline for providers? And again, throughout the whole conversation, these technical solutions are going to be able to help the practice, but they've got to be able to select the right technical solutions and make sure they're cost effective. Next, telehealth. Everybody's gotten a taste of it. It helps our older patients. It helps transportation and mobility challenged patients. And in our pandemic, it's COVID friendly. It's helped keep our patients safe. My mother-in-law has been a beneficiary of a telehealth visit. She has done the doctoring gamut for over 2 years and they couldn't find a solution. She lives in a rural area. Well, she's been able, and like all rural areas, when you challenge your local doctors, you move to a bigger health system. Well, she was able to have an hour telehealth visit with a team of subspecialists. They got all of her medical records from her local doctor. They communicate with her local doctor. They prescribe, and her family was able to attend the visit with her. They did not have to travel 2.5 hours. They didn't have to take a whole day off from work. And she's been able to be prescribed a medication change. And so far, it's working very well. She's followed up by telehealth, and she follows up with her doctors. You're going to have to adjust your workflows. Some people don't like it. I have one practice, they hate it because they think it takes too many employees to do this. But I think you're not going to turn backwards once we've gotten this started. Our biggest question on telehealth is what's the reimbursements rates going to be after the pandemic? Are they going to continue to reimburse for an office visit, or are they going to do like a mid-level visit? The next thing is surprise billing. Last year at MGMA's annual conference, Senator Bill Cassidy spoke on surprise billing. And while it's been put on the shelf for 2020 due to the pandemic, It is expected to be passed in Congress of 2021. President Trump has supported it. It has bipartisan support. I just was speaking with someone today and said Senator Cassidy's continuing to work on this. This will affect hospital-based physicians, mostly anesthesiologists, radiologists, ER physicians. If your hospital is contracted with a managed care payer and you are out of network, depending upon the bill, there's going to be a set reimbursement. It'll also affect physicians that provide services in the hospital if the hospital's in network and they are out of network. There are still a lot of unknowns. I know MGMA is tracking this and will be communicating with its members, and we are too. The thing that I can say is that you really need to be prepared to understand how this could affect your revenue. So now we're on to our learning objective 3, and this is basically some strategies that I have used for years, not only in my medical practices, but prior to joining the healthcare industry in 2009, in some of the businesses that I've worked with over the years. So here we go. I believe in tracking key performance indicators. I strongly believe in cash flow modeling. I believe that it is very important for the medical practice to understand what the cost of their visit is, both direct and indirect. I think you need to have very firm, communicated, and approved financial responsibility policies. Telehealth and increased access to care are going to be a strategy for success. Technology, we're not going to turn back. The cat is out of the bag. And strategic planning. I always have a plan A, B, and C. That's just the way I roll. And that's the way I try to manage wherever I am. So my question to you is, do you have a strategic plan? And if you don't, that's fine. It's always good to get started. But before you do anything, my question is, do you know what you want out of an initiative before you get started with it? So how do you get started? What is your goal? A lot of times I have people call me and ask me questions, and I'm like, what is your goal with this? You know, and I know the real answer is, well, I need to increase revenues. Well, that may not be as easily said as done anymore. We need to have a really firm goal is, I want to increase my days to the next third, and I want to go from 30 to 22. How do I do that? What is your challenge? You know, do you have a wait list of 6 weeks? Do you have a payer that has decreased your reimbursement by 10% and you're going to need to make that up somewhere or reduce your expenses? What data is it do you need? A lot of data, a lot of times I'm using data from a practice management system and my financial accounting system. Again, where are you going to get the data? What exactly is it? Do you need to run multiple scenarios? I always like to try to set my modeling up so I can easily adjust to a multiple scenario. And how are you going to measure and communicate results? Everybody's want to know what you're doing. So I think we've all know what a key performance indicator is. It's a measure to evaluate the success of an organization, employee, or in meeting performance objectives. Your KPIs need to be the indicators that help provide your owners with the information, or your administrators, to make informed decisions and not reactions. That's really easy to react. So what are some of my must-haves? Easy access to comparative data. We have now a lot of computerized dashboards, and they're great. I mean, a lot of us have used QuickBooks, and we can do the double click into a transaction. In these dashboards, you can double click and you can see information. You've got to be able to have comparative data. When I was at the practice, I did manual models. By the time I left, I had 5 years of data I could scroll through. most of the time you were using your historical data to just look at growth and progress. Now, after COVID, it may be even more important to have that historical data is what happens if my revenue goes down to 2017 levels, or let's not be that draconian. Let's say, what if I go to 2018 levels? You know, how can I model my expenses? What could I anticipate? Well, it may not provide all the answers. It may be able to provide a base for some additional modeling or strategic decisions. So comparative data is a must, whether you use a computerized dashboard or if you do a manual one. I can scroll through 3 to 4 years of data in my manual models. You need to have the ability to change your reporting timeframes. You never ever thought this was going to happen, but COVID made it real important to be able to go from monthly updating to weekly and daily updating. I changed my financial modeling on immediately for some that I worked with to I kept track of things daily so I could look Monday to Monday, Monday in April to Monday in February, Monday to March, and then I reported to the partners every week. This provided the partners with some level of assurance that they knew what was going on, and it helped keep them from reacting and making reactive decisions. Like I said, you need to make your KPIs that are relevant to your organization, but here are some minimums, and we know these. You know, we have production. I have charges, payments, visits, work RVUs, contractual adjustments. That's just showing me what the difference of my production is. I have a practice that they track everything by visit. I have a practice that does work RVUs. I've adjusted my KPIs to what is relevant to my owners. Financial, again, you know these. Revenues, expenses, net income. I also believe it's very important to track these non-provider expenses. They're your overhead. How much of your revenues is your overhead consuming? You'll see that down in the ratios. Then your cash flow, aged AR. We all look at our aged AR. But I also, when I was in the practice, I started a model that I tracked my daily deposits by payer. My CEO was like, "What are you doing?" He said he only cared about Blue Cross, Medicare, and United Healthcare. And I said, "Well, yeah, but a lot of this other will add up to be material to the practice." And he understood it. And again, we had years worth that we could look through. From that data, I tracked an average daily deposit. I also do track that for my practices. I use that, and it was a real easy rule of thumb. It's like in North Carolina, if it snows, we close. We don't drive on the roads. We shouldn't drive on the roads. And so I knew if my practice closed that I was going to lose X number of dollars per day when we closed. My executive committee also knew that, and they get used to that data. When I joined healthcare, I was told, remember, doctors like data. And when they start getting used to this on a regular basis, they really enjoy it, and they begin to really participate in the informed decisions. Again, days in AR, gross collections, net collections, non-provider expenses to revenue. I was talking to an administrator last week, and I was like, we were working through a problem, and I said, well, what? She was trying to figure out how much money she could expect. I said, well, you know your charges, what's your gross collections rate? That's going to get you close. You got to know that, and also you got to know if they're changing. Cash flow model. This is my soapbox, and this is a very small starting point for cash flow modeling. I do this for Fulcrum Strategies. I did this during COVID for my partners that I modeled for, because it was really important to see what was going to happen for cash during the pandemic and the slowdown in schedules. This is a roll forward model. I start out with my projections and my budgets, but then I update it every, either monthly, and then during COVID, I updated it weekly, and it was a roll forward. So I would update through actuals through January, once January was done, I would update the actuals, and then it would project out. It's all set up that your ending cash balance for one period is your beginning cash balances for another. For those of us who are older and remember the old cash flow statements, it's the sources and uses. I'm looking at the sources of my funds, and then I'm looking at the uses of my funds. It was also very important for me to teach my owners the importance of, they think income and they think income, but I had to teach them that we had loan payments, principal repayments that didn't hit that income statement. We had capital purchase of computers and infusion pumps that they didn't hit that. And so this is a very important tool in my toolbox. Another soapbox of mine is understanding what the cost of your visit is. And again, I didn't grow up in healthcare, so this is something I had done in other businesses. I'd been in construction. I knew what the cost of building a house was. And so when I was in one of the MGMA pre-conferences that was for financial managers, huge hotel ballroom led by Owen Dahl, so everybody attended. There was probably over 100 people. I was the only one who raised my hand when he asked who knew the cost of the business, of their office visit. See, businesses have to know how much their product or service costs to deliver because that's what they base their pricing on. Because medical practices, a lot of your pricing is set by Medicare or a commercial managed care contract. You haven't had to do this. But how are you going to ever be able to agree to a capitation agreement if you don't know how much that patient is going to cost you? If you don't know how much that disease state is going to cost you? This is, again, a very high level. You have to marry, to be successful with this, you have to marry practice management data units with general accounting, your accounting data. You have to do departmental accounting. But once you get the building blocks built, then you're going to be able to easily mix your building blocks up. I've done it for locations. One of the times when I was real successful with it, I had one location that was very successful. The cost of their visit was much lower than another location. The second location was always asking for more staff. When at a time when we were really trying to control our expenses, I presented it to her. And I said, I don't know how I can approve more staff for you when your cost is so much higher than this. Now, I understand if you've got a high volume, but I'm getting it down to the unit level. And there may be some economies of scale that you could talk about, but this is a catalyst for discussion, and it's a catalyst for making very informed decisions. And it's a catalyst for, if you're not going to be able to increase your revenue, as we always have been, or you're not going to be able to grow into new ancillary services because little by little they're being turned off, the reimbursements are being turned off or cut, then you're going to have to start managing your expenses. And this is a critical tool. And again, I said this is very high level. There are very specific steps in this. Patient policies for financial responsibility. Nobody wants to talk to the patients about money. We are in an industry that wants to care for patients. We want to pretend that it's not there. So what I used to tell my managers, because they didn't want to talk about it, they don't want to deal with it, they only wanted our little financial services 3-person team to deal with it, is I always tracked different categories of expenses, such as support staff, compensation, and benefits, what % of revenue it was. My support staff, compensation, and benefits is about 25% of revenues. And at that time, it was just at the beginning of the high deductible plans, and MGMA was projecting that, we were going to go from 18% to 21, 22. And I said to my managers, our motto always was, the patients pay your paycheck. but we were getting the insurance payments. That was great. We didn't have to talk to the patients. Well, as your patient payments start to become more and more of the revenue, as they approach that 25% of revenues, the patients really do pay your paycheck. We've talked about the effect of unemployment. We've talked about, how patients are going to be responsible for more. Having a written patient policy that is approved by your executive committee, communicated to all your employees, that treat all your patients the same, is really important. One of my examples of why you need this is I had a collector and she was just giving this patient a really hard time, and she was like going on and on and on. And I said, why do you think this patient is not struggling paying their bills? And she goes, well, she has fake fingernails. I said, that's not a basis to make a decision. So even before I had a long written policy, I had some three clear objectives that we had to do to determine if we gave some hardship credits or how we treated our patients. Telehealth visits are going to make your financials much more challenging because, once we start to change how these are going to get paid, are there going to be copays? Companies are going to stop paying the copays for it. This patient is not going to be in front of you. So how are you going to, if they apply a copay to this visit, how are you going to address and collect that copay? Increased access to care. Oh, yep, this is another soapbox of mine. Are we going to be in a physical facility or are we going to be telehealth? Okay, the first thing we need to understand, and I'm sure you all do, is physical facility is a fixed cost. The more you can manage your capacity and utilize it, the better you will be. Again, at another MGMA session, Elizabeth Woodcock reminded us that exam rooms and provider times are like seats on an airplane. The costs are fixed, and once the day is done, the opportunity for that revenue is lost. So you want to maximize that for your financial success. That's going to be even more. Understand your fill rates, understand your days to the next third. Telehealth visits help to capitalize, help to utilize your capacity because they can, a provider can be sitting in an exam room doing those telehealth visits. You're not taking up waiting space. You're not taking up 2 or 3 exam rooms, or they're just sitting in their office. And so you might not have to expand your facility costs to be able to expand your production. The other example of telehealth and access to care, we know what's happened during COVID is it's maybe provide you an opportunity to retain quality staff. I had a practice I was talking to during the first 6 weeks of COVID, and he was telling me he had a provider that was a single mom. She was the only caregiver for her 11-year-old daughter, and she was scared to death of COVID. She did not want to come into the office. Well, managing their telehealth visits allowed them to meet that provider's needs. It's going to also allow them to retain that provider because they went to the mats for her. She was still able to care for patients. It allowed them to have other providers be able to address the in-clinic need. I've had several different strategies that have been successful. I've done controlling templates. For my APPs, I only allowed 2 options. Same-day specialty clinics are very important. And when you increase your access to care, there's some byproducts that the managed care companies like because they reduce the cost of care. The goal of a managed care contract is, or a managed care company, reduce your ER visits. And what I've also found is it reduced the number of phone calls I had. When I was able to allow my patients to have several different choices for visits because I expanded my access, I reduced the number of phone calls. Also, it can help your provider satisfaction because they may take a Friday off if they do a night hour. I strongly believe looking at that, and that could be a pathway to success. Technology, we've talked about it, we live it. Again, a daughter 27 and 32, They live on this. They conduct their business on it. They do things on this that I wouldn't do, but this is what they expect. They also say, I'm not going to go to a doctor that doesn't have patient self-scheduling. I don't have time. So we know we have electronic dashboards to track the KPIs. This could really be helpful to you. My consideration for this is that I would make sure I understand where the data was coming from. I would have an audit to track data back just so I can prove that I'm continuing to be right and not just make an assumption. But that could allow you, instead of the time of manually entering data, to be actually able to interpret. And my goal for dashboards is always to have the answers before my partners or managers had questions. Patient communication, when I was at the practice, we had a large Medicare population, and I was at the forefront of pushing the patient portals. And everyone told me I wasn't going to be able to have a good participation in my patient portal, and we proved them wrong. I told them Medicare patients have time. These grandparents are doing Facebook with their grandparents or with the grandchildren. So at one point when I left the practice, I had over 40,000 participants on our portal. I had a Medicare patient that was not only signed up but using it that was 100 years old. So, it can be done. And also it can help your providers, and it can help reduce phone calls. Patient payments. I used the portal for that first. You have to make it easy for the patients to pay their bills, and they want to pay them electronically. The 27 and 32-year-old daughters only want to pay their payments electronically through their phones. Payment plans. My portal helped me administer payment plans for my patients. They were automatic bill pay. It was fabulous. Transparency and competition. We talked about that, that we have to watch our quality ratings. Are we going to get a price line for providers? Are we going to be competitive? Again, my girls are saying I want patient self-scheduling. A lot of providers do not like that. They want to have control over that. But I think you're going to see the consumerism and the competition demand it. And telehealth. I think telehealth is here to stay. If you ask someone in February, they probably said no, not going to happen. But telehealth has proved vital in this, and we have to have the technology to make it efficient for our practices to offer this service, because there are a lot of benefits to the patients, and there can be a benefit to the providers and to the profitability if it's done correctly. Again, my name is Cindy Nyberg, and I'll be taking question and answers. I'll be taking questions now. If we don't get to them by the end of the session, here is my contact information. Again, I like helping doctors and administrators, and I love hearing what practices are doing to be successful, because there's no one right answer. I want to thank you for your time today, and I hope this was helpful.
Hey, Cindy, extremely helpful. If you could unmute and put your camera on, that would be great. We can field some Q&A questions for you. Cindy, can you hear me okay?
I certainly can.
There you are. How are you?
I'm great. I want to thank everyone for participating today.
We've got a question right out of the gate. Someone asking, can you send your email again? So if you could please, if you're okay with that, if you could just maybe put that in the chat, and we'll get that to you right there. And while you're typing, we'll try to tax your brain again, a little multitasking. This one might be in a little more detail for you to provide an answer for us, but what do you need to do to set up a cost of visit model? How do you go about that?
It is a little detailed, but I think the first thing you need to do is you need to go back and see how your accounting is set up and really start to develop a departmental accounting. QuickBooks, they use classes, responsibility centers, and then you really need to start thinking about which of your departments provide services for each one of your profit centers. Do a little bit of defining and start thinking about your organization. Start with your organization chart. But again, this is a soapbox. I think it's really, really important. And it's going to be important for telehealth, determining how you use telehealth as well.
Okay. And I want to encourage everybody. We do have a few more minutes to field more questions with Cindy. So please put those in the chat area, or you can raise your hand. Maybe we can hear your voice out there. So I've got another question then. What have you seen clinics do to help encourage patients to use telehealth? I know you've talked about telehealth in many ways, but how do you encourage those patients? What's that kind of communication channel to get that rolling?
I think it depends on the practice and the specialty. Like if you take neurology, you've got a lot of patients that are immune compromised. I believe you're seeing the nurses reach out to them and let's schedule. They're looking at their schedules and moving patients to telehealth when you can. I've got an OB practice. Even some of their OB visits, they would like every other OB to try to minimize the risk on getting the patients in there. And then when they're having to do the social distancing and backing down on their visits, they're looking at which visits they can properly do. Personally, I've had 2, and my doctor gave me the choice.
Mm-hmm.
And
Okay.
it's just all a matter of how much you can communicate.
Right,
With your
right.
patient.
Okay. I believe we have time for one more question here. So what advice would you give managers to help them work with the executive team regarding their budgets for the next year? How do you work with them? How do you get that buy-in from the executive team?
Well, the first thing you have to do is you have to report to them monthly. You have to talk to them. You have to get them used to looking at financial data. When I was first doing some dashboard for a private partner come up to me and said, well, I didn't know we had debt. I was like, well, yeah, you do. You really have to do that. And then also, like, sometimes depending upon how extensive it's going to be, you may need to break it up into small pieces. One time I worked with a finance committee, and we were looking at their physician comp, but we took 10 months to do it because we took a small piece of the physician comp each month and then explored it in depth. I might do that with a budget. I'm like, you've had this data, you're used to it. Okay, this is what we're gonna talk about revenues today. You can't talk about it all at once because you don't have, and in my experience, you can't go 2 hours. You have a short window of time to make decisions because doctors make decisions very rapidly.
For more information about the tools Cindy discussed and Whitespace Health, please visit us at www.whitespacehealth.com